technology. Anyway, the topic that I'm going to talk about is abnormal uterine bleeding, particularly in the perimenopausal and in the menopausal period. We started with the post-menopausal bleeding, but I thought that perimenopausal period also is important and that should be included in that. And this whole, as a matter of fact, comes within what is known as AUB or abnormal uterine bleeding. Some of you might be aware of some of the terminologies which were used previously, like menorrhagia, metrorrhagia, or terms like that. But for the last over 10 years, that terminology has become obsolete, and now this is the terminology abnormal uterine bleeding which is used. As we go along, you would realize that how it can identify the various issues and the various etiologies of abnormal uterine bleeding, and also how it will be expressing or will be denoting various gynecological problems which give rise to that abnormal uterine bleeding. First, let's talk about a little bit about what is menopause and perimenopause. You all know that menopause definition is that if the periods have been absent for a period of 12 consecutive months, and this usually happens between the ages of 40 to 58 of women normally. 40 is a little early, but still it is 40 to 50, and 58 on the other hand is late. But this is the range in which after 12 months consecutive cessation of periods or absence of menses, one can say that the person has menopause, and the average age is 51 years. Now, the changes which ultimately lead to complete cessation of periods, they are spanned over quite a few years, as a matter of fact, and when that waning function of the ovaries starts, it may take 4 to 8 years before the final exhaustion of the ovary takes place, which results in complete cessation of periods. And that period during which the ovarian function is dwindling gradually, that is known as perimenopause, and that is characterized by periods which may be sometimes a little longer, sometimes they come earlier. So menstrual abnormalities are not uncommon in that period of time, again, let's say between 40 and 58 years of age, and they would last, as this slide shows, up to 4 to 80 years, which would denote the period of perimenopause. And after, in such a situation, after there has been complete absence for 12 months, then we say that yes, it's menopause. Now, I'll go along with this topic in a deliberate fashion because I want to emphasize more than what is there in menopause and perimenopause, because I would want to emphasize for the postgraduates as to how to formulate an opinion, how to express certain things. It is not just reading and memorizing a definition or certain statistics or figures that would be enough. You need to, at the postgraduate level, identify the evidence for various things, the various studies, various analysis, meta-analysis, and how people arrive at certain decisions or certain conclusions. And therefore, at this level, at postgraduate level, particularly from the point of examination, you need to prepare yourself with arguments as to why you say that whatever your definition, whatever your conclusion, whatever your plan of management, how is it supported by the evidence given in literature. So therefore, I will stop when the time finishes today, but we'll continue it over the next one, maybe two more lectures on, or two more presentations on this particular topic. Now, before I go on to that, because the ultrasound plays an important part in assessment of abnormal uterine bleeding, I would want you to be aware of the appearance of the endometrial cavity and the endometrium particularly, and the uterus on transvaginal ultrasound. That plays a very important role in determining and excluding or confirming some of the causes. Now, in this picture, you see four smaller pictures which show. Now, this is the time when the menstruation starts. During the menstruation, you see some shadows within the uterine cavity. This is the uterus. This on this side is the cervix, and this is the bladder. This is transvaginal, and this line is the border of the endometrial cavity. And within that endometrial cavity, you see certain clots or shedded endometrium. Now, after the shedding is complete and the menstruation stops, then you see here that the endometrium is just a thin line, and here the measurement is given. It is about 0.2 centimeters, so or 2 millimeters. That is this is 2 millimeters. And in the third picture here, this is the typical very nice mid-cycle endometrium, which would be receptive for a fertilized ovum if it comes and gets implanted here. These three lines are said to be characteristic of midline good endometrium, and the thickness here is 12 millimeters.
Which three lines? It's outlined in the center.
Yeah, these three lines that you see, right? These are the borders, and this is the interface between the two. This is the anterior part of the endometrium. This is the posterior wall endometrium, and they meet in the center. And these three lines, they denote a good normal endometrium mid-cycle around the time of ovulation. And even when we are monitoring a woman for intrauterine insemination or other methods of assisted conception, when there are on ovarian visualization, we see eggs being developed and the endometrium like that, it's a good endometrium, right? And now this is the endometrium which later on, because of progestational effect, this is the decidual change that has taken place, but not the decidual change of pregnancy as it is. This is the progestational phase, and it is before the endometrium starts to shed. So this is how it looks in the premenstrual period. So in the premenstrual period, you wouldn't expect it to be like this because it has proliferated. Next is, this is the endometrium on left side that you see here. This is the postmenopausal normal endometrium. Again, 2 millimeters thin endometrium. So this is just like the one that is that you would see immediately after the menstruation has stopped. And this is the thickened endometrium. You see, this is like the one which is before the onset of menstruation, but it is a little even hazier than that. So this is quite thick. If you find this in a postmenopausal woman, so that means something is wrong. Something is the matter. So that's why I even before starting the talk on perimenopausal bleeding, I thought that I will let you know on this. Now, what is perimenopausal bleeding? Again, we know what perimenopause is. This is the time period which is spanned over that, and any abnormal bleeding, whether it is irregular, whether it's increased in amount or it is more frequent, etc. So regularity, volume, frequency, or duration, and especially if it is not associated with pregnancy. So you see, abnormal uterine bleeding takes into factors which are not related with pregnancy. During reproductive life, abnormal uterine bleeding, if there is abnormal bleeding from the uterus, then first thing that you need to rule out or confirm is some pregnancy-related state. Is it early threatened abortion? It is inevitable abortion? It is ectopic pregnancy? Or something. So something related with pregnancy. So once you rule that out, all the other causes are lumped into that group of abnormal or AUP claiming. In perimenopausal period, why it is challenging, perimenopause is difficult to define, because this is the time when the woman can be pregnant. So you have to see, and then distinguishing normal from abnormal uterine bleeding, because at that time we know that because of the waning ovarian function, the ovarian function is not going through the regular phases, and the cycle may last a little longer, or it may last shorter, and it may not be pathological. It may be completely physiological, normal, because the ovary is passing through that stage when its own rhythm is not necessarily the same what it was previously. So it is difficult to define normal from abnormal, and one may or one must bear that in mind when you are finding out the cause or when you are going to treat that. Then it can be, if it is excessive, that you need to manage the patient's hemodynamic status, then that is, of course, known. That's an acute episode of abnormal uterine bleeding. But if it has been, the patient presents with abnormal uterine bleeding for the last few months, then obviously you cannot necessarily that you will say acute AUB, or this is the presentation. This is not the labeling of the condition, but this is the presentation. So in that phase, you can say that she has an acute episode of abnormal uterine bleeding. Or you would say that there has been abnormal uterine bleeding for some time. So not necessarily that you will label acute or chronic. Well, the prevalence of that depends upon the age. Say in 20s, usually there is small incidence of abnormal uterine bleeding. But at the extremes of reproductive age, early, when there is initiation of ovarian function because of the stimulation of FSH and LH, the neurotrophins, at that time, because of the time period that the system takes to get into rhythm, it may take a few months or maybe a couple of years before the menstrual cycle normally establishes. That is at the time of puberty, and that's known as perimenarche. And therefore, at that time, again, one has to adopt an attitude of deliberation, that you just wait and see, etc. And similarly, in perimenopause, again, when the ovarian function is dwindling. And then menstrual irregularities can be shortened menstrual cycle or cycles with or without ovulation. At these extremes of age, the reproductive age, the cycles are likely to be anovulatory as well. And there is one condition. This is known as luteal out of phase phenomena, in which follicles start to develop. As a matter of fact, normally what happens is that follicular development, as I said in one of the previous lectures, probably, or that was in God. In the beginning of the cycle, when FSH starts to secrete that cohort or that group of follicles, which are predestined right from the time that the ovary was formed, that group of 8, 9, 10 follicles in each ovary, they start to develop, responding to FSH. What happens normally is that only one of them that makes or that outstrips the others, and that develops, and the rest of them, they become atrophic. So this is something which happens normally. And when in procedures like assisted reproductive techniques or for ovarian stimulation with medicines, what you are trying to do is that with that medication, you are trying to recruit more of the follicles to develop. So more than one egg may be available, 2, 3, or more. So if you are in a natural cycle, you are doing that. So if there are 2 or 3 eggs, there will be statistically better or greater chance of pregnancy taking place. And if it is to be an IVF cycle, then you want 5, 6, or 7, 8 eggs to be available, so that some of them may not be suitable for fertilize or may not fertilize, some of them may not grow nicely. So, and the purpose is to recruit from within that group or cohort of follicles which were predestined right at the time of the, because those are the follicles which will start to develop in, say, month of August 2021. And so that's what normally happens. At this time of period, in the perimenopausal period, that development may start in the luteal phase of the previous cycle. So that's why that can affect the phase of the development of follicle and the hormonal value of the.
I didn't understand you. Out of phase phenomena.
Huh?
Out of phase phenomena was something.
Yeah, out of phase phenomena, yeah, can normally the follicles start to develop in the follicular phase as we know it immediately after the menstruation starts. When the menses start, you also say that there are two kinds of phases in the menstrual cycle. One is uterine, the other is the ovarian. Uterine is proliferative menses, proliferative phase, and then the what do you call? Secretory phase. And in the ovary, there is follicular phase, and then there is the luteal phase. So the follicles develop in the follicular phase. If the follicles start to develop in the luteal phase of the previous cycle, then their hormone production, estrogen production, etc., will be out of sync. When that is out of sync, that will result in this abnormal bleeding. So, out of sync hormone production because of abnormal response of the follicles to gonadotropins. Again, prevalence cycle shorter, longer, and anovulatory pattern. There may be it may be characterized by spotting or heavier bleeding, and then there is greater likelihood in the perimenopause of structural issues and structural problems like polyps, adenomyosis, fibroids, and malignancy. So these issues also are present in greater frequency at that time. Yes, this is the actually classification that it was announced in 2009 in FIGO conference in Cape Town. I attended that conference. Dr. Asher, Yusuf, myself, Rubina, Suhail, we were all there. We attended that, and I remember this presentation which was given by Ian Fraser. He's an Australian gynecologist. He made that presentation over there. And then finally, later on, it was published in Fertility and Sterility of June 2011 edition, and FIGO classification of causes of abnormal uterine bleeding. Now you all know about that, as a matter of fact. If not, I'll take a little while in explaining this. It is known as, this is the acronym PALM-COEIN. PALM refers to uterine structural abnormalities, and COEIN refers to conditions which are unrelated to structural abnormalities. And then, of course, pregnancy having been excluded, as I already said. Now, this is a good picture to remember it. It shows the palm and the COEIN. This is the palm size, polyp, not necessarily in their order of occurrence or prevalence or incidence, but it is to make that acronym. So a little bit has been manipulated. For example, COEIN is not necessarily COIN, but an E has been added to that. You need to remember that, but this acronym helps you to remember polyp, adenomyosis, leiomyomata instead of fibroids, and malignancy and hyperplasia. So hyperplasia is mostly a benign condition, but malignancy and hyperplasia, they are grouped together. And on this side is the coagulopathy, which is not very common, which is rather uncommon, particularly in perimenopausal period or menopausal period. But in if you take as a whole abnormal uterine bleeding in a woman's life cycle, then coagulopathy is something to be ruled out in younger girls. Then ovulatory dysfunction, that can happen, of course, again at the extremes of reproductive age, but also like polycystic ovaries, which is so common, and that's an ovulatory dysfunction that PCO will fall into this category. And then endometrial, if there is primarily a problem of endometrial, these are also not very common because hyperplasias have been taken over there, so you can't really group hyperplasia with an endometrial. This is like chronic endometritis or things like that, which are not very easy to describe. Iatrogenic, which are caused by, which is rather, I would say, common group, which is caused by prescriptions that all of us do. The kind of medication that we do or prescribe, and it's taken by the patient in a manner. And again, it's important to give that medication in sync with the normal cycle. So if it is in conflict, then there may be a problem. And then the last category is not yet classified, so it will end. Now, when you describe this, when you label a patient as abnormal uterine bleeding, what you do is that you would say AUB, then quote a hyphen or a dash, and then another letter. If you think it is polyp, then you would say AUB dash polyp. It is adenomyosis AUB dash A. Similarly, L, M, AUB, M is malignancy or hyperplasia. AUBC, coagulopathy, AUBO, AUBE, and so on. And also N, if you do not know what is there, or if it does not really fall into any of these 8 categories. So this is how, instead of saying, because that would denote what your provisional diagnosis is, what is the cause of that abnormal uterine bleeding. Now, next, you take into account the fibroids, leiomyomata. These are common. These are very common in the perimenopausal age, in the 4th and 5th decade of life. They are common, and therefore they have gone to an extent in describing. So you would see that a good ultrasonologist, when they describe the presence of fibroids, they will also mention FIGO classification or FIGO sub-classification of fibroids. It is easy to remember. If it is on the lower side, 0 is submucous, completely submucous. And 7 is completely, it's a kind of pedunculated. It's a pedunculated one. And from there, 1 is, which is mostly more than 50% in the cavity, or less than 50% intramural, and more than 50% into the cavity. And 2 is, which is more than 50% intramural and projecting into the endometrial cavity. 3 is, which is completely intramural or just touching the endometrium here. 4 is completely intramural. It is equidistant from the serosal surface as well as, but it is not indenting either of them. And the 5 is when it is more than 50% intramural and less than 50%. So 5 is more than 50% intramural and so on. So this goes on like that. And 2-5, this is when it is projecting into the cavity, and it is also coming out and showing at the surface. So this is how you would name those. And then, of course, if there is greater number of fibroids, then you can say that this is the distribution of that. So it actually tells you what the problem is, that it is AUBL, and then if you AUBL-3, 4, etc., there is a rather complex system again, which I am not going to display here. But if you look at that paper, then you will find a detailed description of that as well. This is a pedunculated intracavity, but this is further description of the same. PALM-COEIN classification already. Now let's take each of these conditions one by one. Sorry, no,
Section for now.
So polyps. Now the figures here are given from certain studies. नीचे बल्कि लिखा हुआ आ भी रहा है इसके. Anyway, उसको नीचे वाले को ना देखो, इधर ही देखो कि in one study, 64 asymptomatic women of around the mean age of 44, it was found that 16% of them had polyps. 16. So, if this is a reasonable number of 64, that the incidence of polyps, you can say 15 to 20%. This is easy way of remembering that in women in mid-40s, no, you see, you can, instead of remembering the exact figures, if you would say that in mid-40s, women are likely to have the incidence of asymptomatic polyps is likely to be around 15 to 20%. Because in this study, if it is 16%, I'm sure that there would be other studies which would say 18%, those which would say it is 14%. So this is how you would say mid-40s, the incidence of asymptomatic fibroids is 15 to polyps is this. And in reproductive with endometrial polyps, if you take all of those women who have endometrial polyps, only 15% develop an abnormal uterine bleeding. Not all endometrial polyps will have abnormal uterine bleeding. There will be silent asymptomatic. And only 15%. So this is important to remember about polyps. Now look at adenomyosis. The incidence and prevalence is very, and depends upon how far you actually diagnose it. Now, many a times patients come with an ultrasound report of fibroid. If it is done from outside, I usually refer them again to our own ultrasoundologists, because they have greater practice of that, to identify that what is the likelihood of this being adenomyosis. Now, for it will be a very embarrassing and difficult situation for a gynecologist to operate on a woman with the intention of removing a fibroid, and with that understanding that the fibroid will be removed. And when you open when you perform laparoscopy, you find that there is adenomyosis, which you cannot completely remove and which might have necessitated or which may have made the patient take the decision of having her uterus removed. So that makes all the difference to know as far as possible, number one, that there is a possibility of adenomyosis. Number two, this knowledge and awareness also makes you lets you counsel the patient in that direction. So this is important from that point of view, that although ultrasound shows that there are fibroids, but there is a possibility that you could have adenomyosis, and if there is adenomyosis, whether it can be removed or not removed, and what would be the other possibilities. So the incidence is quite variable depending upon how accurate the diagnosis is. Now 70 to 80% of women having hysterectomy, or because 40 to 50, the 50s and 40s is the age when there is maximum incidence of adenomyosis. Yeah. And adenomyosis, obviously, this is the same. AUB due to adenomyosis, usually this is not amenable to medical management. You give hormones for a certain period of time, then a surgical treatment is required. Although Marina is or LNG IU system, that is something which is quite effective, as a matter of fact, in many women with adenomyosis, because that provides that low dose of progesterone. So that is one thing. These are quite common. Fibroids.
In our clinic, more than 80% of patients are well responded with Marina.
With Marina. That's all the more reason you should maintain a figures. Now, these are this is the commonest tumor in the human body, although it affects only 50% of the population, that is women. But it still is the commonest, because if you look at women of 50 years, 70% in white and 80% of colored women are, in colored women, it is more common to have fibroids. And now you see so many of them who have had 3 children, 4 children, they have come fibroids. You must have seen when patients come for hysterectomy that if you look at their history, they have had children and still they have fibroids. And again, a quarter of them, not all, a quarter of the women who have fibroids, they have symptoms like heavy menstrual period, and pain is the second most common. Now, these figures I have taken from, this is the recent article. This is New England Journal of Medicine, published only in, when? This is the February journal. It is about relogolix. And one is elegolix. That was the first GnRH antagonist which came in oral form. This is another GnRH antagonist which has come in oral form, relogolix, and it also combines with that norethindrone and ethinylestrone, estrogen and progesterone, to because antagonists, and this is the treatment for perimenopausal fibroids, for pain and for bleeding. So this is oral GnRH antagonist which can be given for a comparatively longer period of time. So this is a good article. If you go on to New England Journal of Medicine site, you can. Now this is again a point which I want to emphasize to postgraduates. The purpose of this reference being given here is that you search, that you go and then you try to find out. There is a topic that you want to know about, then you go. Now the incidence given here for fibroids is taken from this. For others, it is not from the same study. So therefore, I have kind of combined various things. But you need to read this, and when you read that, you would know about the incidence, about the symptomatology and effects, and also the effect of this hormone, and what is the combination therapy, what is the purpose of that. So that one article gives you information on many accounts. Malignancy. When we talk of malignancy here in abnormal uterine bleeding, we are usually talking of endometrial carcinoma. And but at the same time, one must not forget about the malignancies of other genital tract components like vulva, vagina, and cervix. Cervix particularly, because cervix would come as a second thing. But if you have endometrial carcinoma in mind, the peak age is 60, whereas for endometrial carcinoma, for CA cervix, it is 49. 49 for carcinoma, and for CIN, it is the 39. That is the peak age, 39 for CIN, 49 for invasive cancer of the cervix. And endometrial cancer is relatively uncommon before the age of 45, but sometimes it can happen. So perimenopausal women with normal uterine bleeding should be screened with endometrial sampling to rule out cancer. And bleeding patterns are inherently irregular for menopause. Very few actually have hyperplasia. So when we manage patients with abnormal uterine bleeding, we'll take into consideration other risk factors, etc., that we want to rule out endometrial cancer. So this takes care of a PALM thing. But okay. अच्छा, मैं कॉइन की तरफ अभी बाद में आऊंगा. यहाँ पे मैं आपको, क्योंकि हमने वो करना है, मैंने वो स्लाइड्स थोड़ी सी बाद में की, ये मैं आपको एंडोमेट्रियल हाइपरप्लेजिया के बारे में बताना चाहता हूँ a little bit, because malignancies and hyperplasia दो चीजें. Hyperplasias are of 3 kinds: simple, complex and atypical. ये simple की है, benign proliferation of endometrial glands that are irregularly and perhaps dilated, but do not display back-to-back crowding or cellular atypia. Complex की ये definition है, और atypical की है कि there is nuclear atypia and loss of polarity. Now, in the next slide, you see here simple endometrial hyperplasia, and this is the importance of histopathology and knowing a little bit about that and becoming aware of that. I would urge you to go to the lab downstairs और वहाँ पे जो histopathology करते हैं उनसे जरा पूछो simple उनको slides दिखाएं हैं simple सी जाके देखो ये पहले देखो कि columnar epithelium cuboidal और squamous epithelium वो कैसी होती है उनको थोड़ा सा refresh कर लो that will generate your interest into that. Now here you see that there is this shows that irregular glands कोई बड़ा है कोई छोटा है लेकिन वो दूर दूर अपने पड़े हुए हैं और cellular atypia उसमें नहीं. Now this is the high power view of the same slide in that area that you see that the cells are kind of regular, the nuclei are regular, but again I would say that only histopathologists can guide you on that. और अगली स्लाइड में अगर आप देखो तो ये इसमें इतना क्लियर नहीं आया हुआ अगर उसको करेंगे तो वैसे है इसमें कि ये दिस इज द व्यू ऑन हिस्ट्रोस्कोपी ऑफ द एंडोमेट्रियम. इसमें कॉम्प्लेक्स इसमें के ब्लड वेसल्स नजर आ रही है और इरेगुलर एंडोमेट्रियम एंड ब्लड वेसल्स नजर आ रही है एंड दिस इज कॉम्प्लेक्स. इफ यू कंपेयर इट विद नाउ द सिंपल ये वाला देखो आप ये वाला और ये यहाँ पे ग्लैंड्स देखो तो उसका कॉम्पैक्शन नहीं है जहाँ यहाँ पे कॉम्पैक्शन है और यहाँ पे अगर न्यूक्लियाई अब यहाँ के देखो ये वाले और ये वाले देखो so there is that kind of difference between this complex hyperplasia and अब एक चीज जब hyperplasia की हम बात करते हैं तो उसमें important चीज ये आती है कि how does any hyperplasia progress, regress or persist? अगर आप यहाँ पे देखो तो simple में out of 93, 80 regressed, 19 persisted and only 1 progressed. Whereas in complex 3 or complex with atypia, उसमें 29% जो है they progress to cancer. So therefore atypia is something which is important here. Simple with atypia उसमें भी ज्यादा है simple with atypia. So atypia is something to be looked for and then dealt with. So these are, remember that there are simple, complex and atypical. और वो उसमें उसकी क्या है आज हम इसको यहीं पे छोड़ते हैं क्योंकि इसके बाद फिर इसकी हम वापस जाएंगे यहाँ पे ये अदर साइड. ठीक है ओके. आज वो नजर नहीं आ रहा हमें. वी डोंट नो कि क्या वो क्वेश्चंस किसी के हों तो उधर उन्होंने बुला लेना तो सैफ को. जरा वो स्क्रीन पार्टिसिपेंट्स की स्क्रीन में दिखा देंगे कोई क्वेश्चन हो तो हम देखना चाहते हैं.
क्वेश्चन कोई नहीं है आप अभी कंटिन्यू कर सकते हैं. डॉक्टर यूसुफ ने इसी क्लास में डॉक्टर यूसुफ अच्छा सेक्शन पे जा.
डॉक्टर यूसुफ क्या कह रहे हैं
इसी क्लास में कंटिन्यू करेंगे.
उन्होंने आना क्लास लेनी नहीं. मैं अपना टाइम शुरू चाहे वक्त पे करूँ ना करूँ खत्म जरूर वक्त है. ये क्या है zoom the pictures where is screen if notes slides are can you please remove your mask? लो और remove कर लिया. अगली दफा मेरा हाल अगर मैं ऐसे बैठा हूँ तो I can remove my mask. लेकिन at which endometrial thickness endometrial biopsy ये चीज आगे आ रही है which I am going to talk in quite greater detail that the thickness of the significance of thickness of the endometrium, how to determine that, what modalities are there, how are we going to take biopsies, what biopsies are current and what are now outmoded, and how does women of reproductive age with polyp present and their bleeding. You see, in this was shown in the slide that women with polyps, endometrial polyps, only 15% of them have symptoms, whereas if you scan about 15 to 20% of the women would be found to have in the perimenopausal age to have polyps. 15% will have polyps, and out of all those women who have polyps, they only 15% have symptoms. So 15% जो है ये बड़ी जगह पे आता है. Abortion rate क्या है? Miscarriage rate 15%. Pregnancy rate क्या है? Natural pregnancy rate क्या है किसी cycle में? वो 15%. तो मैं बल्कि जब पेशेंट्स के साथ बात करता हूँ तो थोड़ा सा वेरी कर देता हूँ कि हर चीज के 15% बताया जा रहा है, but 15% is a figure which comes handy in BM next class में discuss करेंगे. हाँ जी, how we differentiate between submucosal fibroid and endometrial polyp. Well, the endometrial polyp, that's I think that's a good question, and you can find it or you can go to Google for that. But fibroid will have on histopathology, one is in general appearance. Fibroid, submucosal fibroid will be a little larger, and it'll be of kind of mostly it'll be a rounded shape. But if there is a conglomerate of fibroids which I recently removed, वो fibroid polyp हमने myomectomy की थी और उसके वो there was a kind of bunch of fibroids like that, some mucous fibroid. But fibroid usually would be a circumscribed thing, and polyp is usually a kind of elongated after some time. And on histopathology, there will be fibrous elements in fibroids, and endometrial polyps obviously would consist of endometrial lining. How we differentiate between submucosal and endometrial polyp? Their bleeding pattern. Well, bleeding pattern in polyps would be less likely to bleed because only 15% is symptomatic, as we now know. But fibroid polyp is more likely to give rise to symptom of bleeding and pain. Submucous fibroids are more likely. We know that 25% of fibroids are symptomatic, but submucous fibroids would be more likely to produce symptoms. हाँ जी, यूसुफ साहब आगे चलेंगे. कोड नेक्स्ट लेक्चर. चलो ठीक है. Over to you, Professor Yusuf.
नहीं सर, थैंक यू जी.
उनको ये आवाज आ रही है.
अच्छा सर, ये जो बात अभी कर रहे थे,
हाँ मैं अगली टॉक में मैं पोस्ट मेनोपॉजल ट्रेनिंग को खत्म कर दूंगा. ठीक है, तुम तो बड़े मजे से हो. मैं वो अंडर.
अच्छा ये सर बात कर रहे थे अभी फाइब्रॉइड्स की और ये पॉलिप्स की, लेकिन इसमें एक बात याद कीजिएगा कि जो इसका डेफिनेट डायग्नोसिस है दैट इज थ्रू एन हिस्ट्रोस्कोप एंड देन उसकी बायोप्सी एंड देन टेकिंग इट आउट.
बिल्कुल. हाँ जी, बिल्कुल बिल्कुल.
ओके, अब आई थिंक वी गोना मूव ऑन टू द नेक्स्ट केस. वो किन्होंने प्रेजेंट करना था?
जी अस्सलाम वालेकुम सर.